assessing, recognizing the pain, and strategies have evolved in management of pain as per the WHO analgesic ladder, be it the pain because of the disease per se or because of procedural pain. So we have been giving services in neonatal and pediatric palliative care since 2019. But today's topic is very special to me because we started this in June 2024, perinatal palliative care. So today we'll be seeing what is the features of perinatal palliative care, how do we support the needs of the parents in this setting, managing pain and other symptoms of the neonate, be it breathlessness, be it a wound management, be it secretions, or be it any other neurological symptom, who are needing perinatal palliative care. We all know every baby's life is very precious, and definitely there's an interdisciplinary approach that is required, which is very flexible and focused on life, allowing for support and compassionate healing. So this perinatal palliative care service is given for those families who are unfortunately expecting a baby with a life-limiting or a life-threatening illness, what we now coin as a child with a serious illness or a fetus with a serious illness. Why do we need perinatal palliative care? Unfortunately, majority of the perinatal losses is seen to be in middle income and lower income countries, maybe because of poverty, illiteracy, early marriages, no spacing between pregnancies, lack of ignorance of folic acid, consanguinity, and many other factors. So this support during pregnancy with decision making before and after birth and throughout the grief process. The perinatal palliative care honors the baby and parents. There is relief of suffering, addressing of pain and all the other symptoms, affirms life and regards dying as a normal process with dignity. And this can be provided to the baby along with the medical care what the baby is undergoing. And this results in a different kind of hope for such family in grief. So perinatal palliative care is an spectrum of palliative care given to an antenatal couple who's diagnosed with carrying a fetus with an abnormal congenital anomaly, which might be life-limiting or life-threatening. So this care starts right from the diagnosis, goes throughout the pregnancy. We are there for the delivery. After the delivery, we take care of the baby as long as the baby is alive, treat the symptoms of the baby. In case the baby doesn't make it, then we give end of life care, and then it is followed by bereavement support. Now, some families, knowing that they have a congenital anomaly, they go in for termination, but some families just want to experience they want to have the experience of childbirth and the bonding of being a parent, however long the child lives. It might be hours to days to weeks. So these parents, whatever decision the parents take, either whether they want to terminate or they want to continue, we support them in their decision. So what is a perinatal palliative care communication all about? It is the same of palliative care wherein we talk to the parent in the model of spikes. That is, first we ask them what they know about the illness, how much more they want to know. We tell them in the steps of spikes pattern, and then again ask them if they have understood, if they want to know more. So we need to introduce the concept of caring for the baby when the baby is born, and holistic pain, that is spiritual, social, and psychosocial support for the parents, siblings, and extended family. This should be, however, done with the right people who are taking the decisions in the family, and also with the right healthcare team, being the pediatric palliative care team or the perinatal palliative care team, the neonatologists and the obstetricians. So we need to give them the information slowly and tell them that with the hopes for the time with their baby, we would be planning exactly medical care and a plan for the baby after the baby arrives. And these sessions does not happen once. It is multiple sessions of counseling, sometimes with the parents, sometimes with the extended family, and sometimes with the neighbors. And because a child is so precious, many people get involved when it comes to a child. Sometimes community gets involved, teachers get involved, close family friends get involved. So there are multiple sessions of counseling. What we explain to families is that perinatal palliative care, what we give, is offered to the parents and families who are told that their baby might live very brief. So after receiving this news, Definitely, they are disheartened because pregnancy itself is a beautiful journey of happiness, hope, and dreams. And then, after discussing and counseling, then they choose to continue the pregnancy and celebrate the baby's life, however the baby long the baby lives, and then make memories. So what we explain to the families is definitely have found to, these families have found this journey to be very meaningful and healing, because we also had a bereavement support group which we conducted on World Palliative Care Day, wherein we invited the perinatal palliative families who lost their babies. The bereaved parents came, and this is what they shared. So this care offers specialized care and support to the family throughout the pregnancy, after the birth, till the baby lives, and then death, and then bereavement. Now, who are the babies for whom we give perinatal palliative care? So genetic conditions, renal like autosomal recessive kidney disease, renal dysplasias, renal agenesis, uh, massive hydrocephalus, hypoplastic pons, absent vermis, big meningomyelocele, ruptured meningomyelocele, encephalocele, hypoplastic left ventricle and complex congenital heart diseases, and babies with multiple severe anomalies and skeletal dysplasias, and CDH with very bad hypoplastic lungs, and also duodenal atresia is in gastrointestinal. This is a very, very important slide. It's been found that even with the babies who are born with trisomy 13 and 18, the median age of life for this baby can be 10 days. And 10 days lived is life. So we should not use the word lethal or incompatible with life, because life lived even for 10 days is life. Coming to the most important things for the families when a baby is born is receiving ongoing support in the location. It can be the hospice, home, or hospital. Having unlimited time along with the family and siblings with the newborn. Being allowed to encourage. So we allow to encourage whether the mother wants to feed, the mother wants to give a KMC, the mother wants to dress the baby, give a bath to the baby, having the baby's siblings as I mentioned. And symptoms, be it pain, be it the wound, be it dyspnea, secretions being well managed, and planning for the unexpected if unfortunate. So we tell them the possibility of fetal death is around 30 to 45%. Even a vigorous appearing infant at birth, 30% die within 48 hours, and then 55% die within 5 days. Some live for a month, and then 84% die within a year. And there are 8% babies who might survive, of course, with symptoms beyond a year. So coming to the decision making and creating a plan, the healthcare provider should give honest information about the illness and the prognosis with lot of sensitivity and empathy. So in palliative care, we follow the serious illness conversation guide where we use the terms wish, worry, and wonder. I wish your baby will live as long as possible, but I worry that maybe this anomaly may not allow the baby to live for long, but I wonder how comfortable I can keep this baby as long as the baby is alive. So we usually use these terms. Now, parents focus on the emotions, hope, religious and spiritual beliefs, and the exploration of their relationship to this baby, what hopes they had, what dreams they had for this baby, and then we come out with a congruent care plan. Most often from studies, it is found that the parents want guidance from the doctor and not us telling that you decide what to do. Benefits of perinatal palliative care. In pregnancy, it's an already phase very new to the parent. Decrease parental anxiety and stress once they come to know about the anomaly. The family is able to experience the birth of the child and bond with the baby as long as possible, even if it is for few minutes. It enhances the parents and co-families to be feel supported in the decision making and throughout coping of the death of the baby. And even the infant gets dignity like any other child or individual with terminally illness. So there is this expert palliative care team who has a lot of sensitivity and empathy addressing this parent and family and the baby throughout the journey. So when we talk to parents, what do they share? They are so scared how their baby will look, what kind of anomaly will manifest, because they don't understand the medical terms, and what will happen, how will the baby die, and what will be the reaction of the sibling, And coming to hope, many of them share that everything might be wrong, the TIFA scan might be completely wrong, maybe my baby will be born completely normally, and then they'll get time with their baby because of the care plan. A special blessing can happen, and also this baby will get time to meet the siblings. So when we create a birth plan, this allows parents to be actively involved in their baby's care, and it's always important for us to give them the choices about the care so that they will be in full sense of control. And this should again happen between the family, the neonatologists, and the obstetricians. Otherwise, if there is this loop is not there, then the right perinatal palliative care will not be delivered. So in the birth care plan, we tell the parent that we would like to honor the baby's living, minimize his suffering if any at that time or later, and share as many meaningful moments with him as possible. So memory making is a very, very important part of palliative care. We say making memories and memory making. Making memories what happens unknowingly, and making memories is something tangible what we make with the babies and parents as per their wish, so that they can remember and feel it later when the baby is no more. Perinatal palliative care birth plan involves the care of the mother and baby during labor and delivery. There is a mutual discussion between the obstetrician and the palliative care team and the mother about the timing, route, and location of baby's delivery, the extent of management of pain, and the cardiac monitoring of the fetus. And if the parents have the strong desire to meet the baby alive, then to allow the family members in the theater or the labor room. And different faith and prayers or rituals that can be initiated as soon as after baby's birth. We have done this. I'll show you a few of the things what we have done later, because we had babies who lived only for 2.5 minutes in the theater. And because perinatal palliative care got involved, the grandfather could come and name the baby, hold the baby for 2.5 minutes, and the baby died. But it was a good end of life care, good death, and a memory making for the baby. And who are the healthcare providers who will be present during delivery? One thing is palliative care is not only end of life care. I just want to emphasize, because everybody thinks palliative care is end of life care. No, palliative care starts from day one of diagnosis. It is integral part of care. Initially, it is care of the symptoms, and later we tell the parent that hope for the best, then hope to get good control of the symptoms, and later, in case the baby worsens, you have hope for a good end of life care, and we call it a good death. So there should be always hope. Only the reason for hope might change in the trajectory of illness. Initial care management of the baby. There are parents who even say we don't even want a IV cannula. There should be no pain for the baby, no intubation, just give comfort care. So everything is specifically written down, discussed with the neonatologist, and then planned. And in case there is pain, dyspnea, seizures, or other symptoms, then we have pharmacological and non-pharmacological management. So again, we give a lot of time for the siblings and the extended family for memory making activities. And then also we help them in communicating this to the other family members who are not in the hospital. In the NICU, it's again routine care, including warmth, KMC, and skin care, as long as a baby can take and as long as a mother wants to give. Of course, we also have a milk bank. So the bereaved mothers are encouraged to give the milk into the milk bank as long as they're in the hospital. So our perinatal palliative care team also takes care of the lactation issues in the mothers. And as I said, there are parents who say we don't even want a cannula. We just want comfort care for the baby. So then we make a care plan that even a cannula or even one CBP will not be sent for the baby. But this all has to be communicated well in advance with the neonatologist so that the plan will be made as per the parents. Then we can decide if the baby needs to continue in the NICU or the baby can be kept with the mother in the postpartum ward. So these were the conditions in a neonate for whom we were giving neonatal palliative care since 2019. But of late, since we have started perinatal palliative care, there's a lot of overlap. So in case a mother comes with an unbooked pregnancy and we have no perinatal palliative care referral earlier, then these were the babies whom anyway we used to see either for pain, either for compassionate extubations, either for wound management, for counseling, for end of life care, or These babies used to be either seen in the hospital initially. If the baby needed respite care or end of life care, we would shift the baby to the hospice. If the baby needed only symptom management also, we could shift the baby to the hospice, and then we register under home care, and then we take care of the baby at home. So these were the conditions where neonatal palliative care was already existing since 2019. So how is neonatal pain assist? A brief note on this. I'm not going into the details. Usually with the behavior of the infant and physiological parameters. So I'm again amidst distinguished neonatologists. So it's all of us are aware that all these can be signs of pain and distress in a baby, and even a preterm baby can sense pain because of the various factors that we know. So no baby should be in pain, and our policy in our hospital is say no to pain. We use in our hospital, we use the NIP scale and the PIP scale to score the pain, and any baby having a NIPS of 3 or more are treated again by the WHO analgesic ladder. So usually the neonatologists start paracetamol. When paracetamol doesn't work, then we get a call for opioids. So coming to the pharmacological management, we use morphine in a very small dose, 0.05 mg per kg, and in preterms 0.03 mg per kg, buccal. We use midazolam for dyspnea. When we do compassionate extubations, we use fentanyl followed by morphine and glycopyrrolate. Glycopyrrolate is given for secretions, or even atropine can be given, but atropine crosses the blood-brain barrier, so we prefer glycopyrrolate. Amla is a mixture of xylocaine and prelocaine, 2.5%, which we use as a local anesthetic. And non-pharmacological techniques are already being done by all the neonatologists, like sucrose, breastfeeding, swaddling, KMC, reduction of noise and light, and massage, music. And we say cluster the procedures. You try to send all the procedures at one time so that the baby is not pricked multiple number of times. So for pain treatment pharmacologically, we can use paracetamol, morphine, as I said, and fentanyl. This is a non-pharmacological management, is facilitated tucking and swaddling. KMC, as we have all spoken in the morning about, there was papers being presented, breastfeeding, non-nutritive sucking. Even for a baby just born and we know the baby will be living only for hours, we encourage non-nutritive sucking so that the mother also will have satisfaction that she tried to feed the baby. And it's better to call the family members to the NICU during the procedure time so that they can hold the baby, or they can give comfort care and also reduce the noise and light in the NICU. And most often, even the simple diaper causes a lot of distress in the baby. So it's always better to use a customized diaper. Oversized diapers will again result in NIPS being more than 3. And coming to other end of life care in such perinatal babies born with anomalies, you can have different type of breathing which we need to recognize and treat. They can have gasping, paradoxical breathing, gurgling, or irregular respirations. Now this is all explained to the parents because they may not know how the baby is going to end life. So they will be very anxious and restless. So we tell them that these respirations can be there and this is going into end of life, and we are all there with them throughout, supporting their emotions along with the distress. So again for dyspnea, we use a half the dose, 0.025 mg per kg of morphine. And second line is midazolam, again 0.05 mg per kg. Even if the baby is very sick, and many a times if even oral feeds are not allowed, we can always give buccal. Even if they write NPO orders, we give buccal because buccal absorption of morphine is very good. The other routes where we use is IV and subcutaneous. We keep a subcutaneous port because IV cannula insertion is again pain. Because it's all about no pain and comfort care, we try to do what's best in that given situation. So this noisy breathing, what we call death rattle in bigger children, is most distressing actually to the family and not to the baby. The baby may not really suffer with these secretions. So we need to provide a lot of reassurance to the parents that the baby is not suffering, but because of a decreased tone or because of the posterior pharyngeal secretions, the baby is not able to swallow the secretions well, and the parents will be very frightened. So we do use glycopyrrolate, 1 drop, or atropine, 1 drop orally. The same eye drops we use orally to decrease the secretions. Positioning and light suction also helps. So there are children parents who want end of life care at home sometimes. Sometimes they want the end of life care in the hospice or sometimes in the hospital. So if we know that the baby is going to live hours to days, then we give them the option of going to hospice or going home. But if we know the baby is going to die in minutes, we give the end of life care in the hospital itself. Of course, it is challenging because they are in the same NICU where the other normal babies are. We don't have separate palliative care ward in the NICU, so the privacy is less. So it becomes a little difficult for memory making and to give good privacy time for the family to spend with the baby. And most of the labor and delivery unit in most hospitals may not have a lot of experience in providing palliative care. And these families will be hearing, the mothers will be hearing other babies crying, and that will make them even more distressed. So what I have seen abroad is that it's not possible and practical in our setup. They have a picture like a fallen leaf or a drooping flower on the door of that particular room, so that already people are sensitized that when I enter the room, that I have to behave in a certain way because the baby is either sinking or the mother is already lost the baby. But in our hospital, it's the other extreme. We have so limited beds. So what they do, they keep one mother with a baby and another mother who's bereaved, who doesn't have the baby. So they two plus baby fits in a bed. So it's very difficult. So usually when we go, we just try to put a screen and take her to another empty bed for some time, talk to her, and then do the whole process of bereavement. This is all very ideal what happens in the West, but it's difficult in our setup. So once we know that the baby is going to live for weeks to months, we have many babies. We have a baby with hypoplastic vermis, hypoplastic pons and absent vermis who was given perinatal palliative care. Now the baby is 8 months old. The head circumference is around 34 centimeters at 8 months, and the baby is continuously has tremors. Baby is on clonazepam. So these babies are followed up in home care. There are many babies like that. So when they are discharged, if we know that the baby is going to live for some time, then we register under home care. However, we always have a care plan, a crisis plan, and an advanced care plan. So crisis plan, in case the baby suddenly aspirates, in case the baby has a seizure, what they are going to do? They should again not run hospital to hospital and do again a doctor shopping for the baby, because we make an advanced care plan saying that your baby will not survive. So it is best to give comfort care as long as the baby is alive. So there is also a advanced care plan made, and location of death which the family can choose, and our contact numbers are always given to them, and options of memory making is always given to the family. It's never made compulsory. It's option to them that this can be done, and whatever type of memory making they want, then we do it. We do send the babies with a small diluted dose of morphine home if we know that the baby is going to survive only for a few hours, and the parents want to take the baby and show the grandparents and the other people at home, then the baby is sent on morphine, oral morphine. So we need to plan for the baby's care, as I said, when the mother is discharged. And for us, because we have a hospice, so we have a transition of care between hospital, hospice, and home, and the baby can go around these places. So time as a precious source is very important for a mother who's losing her child. By touching and holding the baby, giving KMC or kangaroo father care, rituals of blessing, naming, and dedication depending on the religion. Just making the baby wear a dress, or just lying down next to the baby, or just kissing the baby, or putting the baby to the breast also makes a lot of difference. And siblings holding the baby, siblings interacting with the baby. So perinatal palliative care provides ongoing support all through the pregnancy, allows time for the baby with a life-limiting or life-threatening illness for the family and the baby, encourages activities to promote memory making and sibling involvement and bonding, provides comfort measures to the child, and supports the parents to develop a plan for their baby however they want. Again, bereavement follow-up is done with a phone call around 10 to 14 days later. And in case they are in Hyderabad, then a bereavement visit is also done, because we have babies coming from the districts and the city. In case they are from the districts of Telangana, then we do a phone call follow-up. So a mention about the perinatal palliative care, what we started in Nilofer Hospital in June 2024. So initially we thought even would be happy if we get 10 babies in 6 months. But I'm very glad with the great cooperation from our obstetric team. Today we had 142 referrals of perinatal palliative care, of which 62 babies survived and the rest are not there. But they all got symptom management, comfort care at birth, and all the services what I already mentioned. So we have here almost 12 to 15 babies being born with a congenital anomaly. So initially we did sensitization with academic sessions to the obstetricians so that they will also know when to exactly refer. So we had a referral from the OP and IP, and then we used to call them the family for counseling and then make a follow-up plan. Many times it required networking between the fetal medicine person, the radiologist, the neurosurgeon, the pediatric surgeon, because if they would have had a surgical anomaly. And then a birth care plan was made, and our team who have pediatric palliative care nurses trained in perinatal palliative care and a social worker support these mothers in the labor room and the theater, and networking with the neonatologist as to whether to intubate or not intubate, to put a cannula, not to put a cannula, send a CBP or not to send a CBP. As I said, lactation support for bereaved mothers and continued support to these babies in hospital, home, or hospice-based palliative care, memory making and bereavement. So as I said, we have the hospice also. So our babies they get continuity in care among these three places. So we observed maximum by neurological. This is just to show our statistics, followed by complex cardiac. 36 were neurological and 28 were cardiac, and the others followed in sequence. So we attributed it to folic acid deficiency. So we spoke to the obstetric head, and she wants to introduce folic acid in the Kalyana Yojana scheme so that folic acid is started even before the conception, which is actually the guideline. So we did naming the baby, cradling, pictures of holding the baby, hair lock and sticking the baby. This is all after the parents wanted it. Foot and hand impressions, just few pictures. This is a cradling ceremony of a baby with MMC, ruptured MMC, bilateral paraparesis, and baby was not going to survive. This is a baby with a hypoplastic left ventricle. Before day 5, we did the mother, father, hand impression and the babies. This is a baby with hypoplastic vomits, but who is still alive. This is a baby with congenital diaphragmatic hernia and very bad hypoplastic lung. Post extubation, post compassionate extubation, before they went home. Thank you so much. This is our it looks so serene and nice. It's our Mandara Children's Hospice, 10-bedded children's hospice, and below is the adult hospice. So where we give symptom management, respite care, and end-of-life care. Thank you so much.
This is a wonderful talk, very clear. I think I had some doubts, so it got sort of described very clearly in your talk. So I think we will try to reiterate this on case scenario when we have a panel discussion.
Sure, sir. Thank you.
It's open for anybody who wants to ask anything. Yes, please.
Very good, Dr. Archana. Thank you so much. We have a sort of palliative care policy or protocol, but there are two struggles that we have. One is when we know we are giving palliative care, like you said, we would like memory making, the patient to be bonded, but there's also people who think the baby is going away. Why stress the mother? Why get her to bond? And especially the family may try to sort of protect the mother. And I see that kind of thinking among our own nurses and doctors at times. So that was one, how to deal with it, particularly from the family. They may not have been exposed to this concept from the beginning. And the second question was about withdrawal of life support. Many of these babies may be on ventilatory care, and there are different schools of thought. For example, the protocol from KEM, which you may have, they don't talk about withdrawal. They say continue to ventilate. And our laws, there are no clear laws. So how do you go about giving palliative care Do you withdraw babies? How do you all go about it? Thank you.
Thank you, ma'am. We face this very often. It's not that every baby and every situation it's very easy to give palliative care. As ma'am said, so this all I think boils down to a very good communication with the family and the mother, and the collusion that how sick the baby is, even the mother should know. So many a times when, as ma'am said, the bonding. So we just tell her, since you have come to the hospital, how long has it been? It all boils down to a good communication. What we train for spikes and the serious illness conversation guide, wherein we say, so in these 30 days, how do you feel your baby is doing? So she says that my baby is in the cradle. And then when we ask her, have you been able to, do you like to do anything with your baby? Do you feel like holding the baby? Or do you feel that you're not having enough contact with the baby? Many a times the mother herself says, she just breaks down. And then because we have that pattern where we ask and give pause and then ask them to speak. So many a times in the first counseling, we just tell them about the baby's illness, and slowly we get to know what the mother concerns, fears and worries are. And sometimes she's not able to really vent out. So over the conversations and multiple counseling, then we get to know there's no force on any family for any kind of memory making. We always say some families would prefer, if you know that your child's life is limited, if you know that you have very limited time with your baby, what best would you like to do for your baby? So then we just leave it at that and say some families like to do this, some families don't want to do this. You can tell us, in case you want to do anything for your child, then you can let us know, we'll help you. And coming to compassionate extubation, ma'am, we always say that it is better to withhold than withdraw. But withholding is difficult because when the sick baby, preterm baby comes, first thing is the PG does is intubate. So usually they refer to us saying that please counsel about poor prognosis the first time. Then first, second, third time, then they say please continue poor prognosis with talk about compassionate extubation. So then when we talk to the parents, many a times as our conversation proceeds, they only say that we feel we are giving suffering to the baby is not comfortable, we want to go home. So then we say, do you know the consequences of going home? Then they say, yes, we know the consequences, but the baby's every day CBP is being sent, and day by day the baby is deteriorating. And I know that the baby is not going to improve. However, I feel at least the baby should not suffer. So there was a mother actually, 58 days baby was in the cradle, and she came and actually we didn't know whether we should talk to her. So we spoke to the family. When the family went, she came alone to us back and said, I have not carried my baby. I want to go for a compassionate extubation, but my one request is to do it in my arms. I have not carried the baby, so please keep the baby in my arms and then do the compassionate extubation, and I want pictures of the baby in my arms. So that was one compassionate extubation which was really difficult for us to do in her arms. So the baby had the last few breaths in the arms itself. So when we talk and have, it boils down to a good communication about what they understand and what they really want for the baby. So I think we do face such situations, but and we are principles of palliative care is beneficence, maleficence, benefit, justice, and autonomy. So when we know that baby is not going to benefit from a ventilator, then even the tube being there is not good. So we always say risk versus benefit, and then they come to a diagnosis that, I mean, a conclusion that no, we don't want this, we want to go home. So then we say, fine, if you want to go home, we'll make this process, because it lama means they will go with that bag and that tube inside the outside the hospital. So we'll tell them that we'll make this process very comforting for you. If you think back after a week or after months, how your baby's end was, you should not regret. So then we do the process of compassionate extubation with the, after the neonatologist writes and gives us, it's a shared decision between the family and us. Mutual consent is taken, father mother sign. The neonatal also they write DNR and DNV. I mean not DNV, DNR once a tube is removed. So there's a process for which we use all, we soak all the plasters that are there, slowly remove the plaster one by one, keep either the RT or insert a subcute cannula in case we think morphine cannot be given oral. We give one dose of fentanyl before extubation, remove all the plasters, and last the ET tube is removed. And after that, the challenge what we faced was Once you do a compassionate extubation, the neonatologist says now you can't keep it in the cradle because again they have to intubate. Then we don't want them to go back home because the baby might die on the way, which is the worst. We don't want the baby to have such a type of death. So if we know the baby is going to live for us, if the heart rate is good, and generally when we assess, then we immediately shift the baby to the hospice, which is 7 kilometers, and their end of life care is given. What I face is if the baby is going to live for a few minutes, then they don't know where to stay. So I just bring them to my OP room, and then we make them sit. We give them water. Then we allow them to read the Bible or whatever prayers they want to do, and we bring all the family. We have arranged. We have just made it out of for our situation so that we give that kind of care, and we make them sit in our room for maybe hour, 1 or 2 hours, and once the baby dies, again the neonatologist gives the death certificate, and then they go home. So it's not easy, but we try to do it.
Sorry to interrupt. Actually, I have two scenario left. One is already asked by you. So we will see that. And after that, if we have doubt left, I think if we have time, we will discuss that. So this is about one of my recent experience that was pretty traumatic. Actually, this mother came to me at 38 week. So antenatally scanned 20 weeks normal. 28-week growth scan, they found hydrocephalus. And the plan by obstetrician discussed with them, because it's a primary mother, they are going to do craniotomy and deliver normally, try to deliver normally. So she came after that to discuss with me. So her first question was, what will happen after delivery? So Nishad, Dr. Uma.
I think so we need to be very clear and give her unambiguous answer at this point when mother is going to ask like what is going to happen. So we have to say that during the time of birth, we will be there, our resuscitation team will be there for the baby. And like we will be observing the baby, not to do an active resuscitation as such, but have to look for signs of life because we have to value every life. So during the assessment, if the baby is going to take spontaneous breath and have signs of life, definitely like we would like to take the baby into the NICU and give a comfort care. So the comfort care, as already mentioned by Dr. Archana, would be if there is respiratory distress, we have to give oxygen. If there is like we cannot deprive the baby of glucose or sugar. So usually because to avoid pain, we put an umbilical line. To cut the cost of umbilical catheter, we put a NG tube instead of umbilical catheter and put some dextrose strip and give that kind of dignity of life for the baby, not to just leave in the labor room, not not involving neonatologist as such. So I would like to kind of clarify what is our role as neonatologist in the care of the baby. But of course, if they are going to do a craniotomy and deliver, we might kind of expect a stillbirth at that point of time. So we need to explain like what exactly is the situation, what a mother can expect.
So, so followed explaining something very similar to her. So her next question was, suppose if baby lives, how long baby is going to live?
So actually, like before, we are actually I took it in the route that it is something incurable. Okay, so there could be conditions in the hydrocephalus itself, like where there could be acceptance from the family that the child can be developmentally delayed, but we could do something about it. So I would, as a neonatologist, I would definitely try to discuss that part also. But I took this route because of the topic as palliative care.
No, exactly. So what happened that because the brainstem is not abnormal here, so they may keep on breathing, and like ma'am was also presenting data that some of them may keep on breathing for even months together. So because we don't have a setup where we can send the baby to die. So question here was asked to me, can you keep the baby in the hospital till the baby die? then when I say that, okay, suppose if I keep in the hospital, minimum thing that we'll do is we'll feed or we'll give glucose. So with that, baby may live for longer time, and we don't know. So then her thing was, can I take the baby home and starve the baby to death?
So generally we do
You
not.
can, ma'am wanted to answer something.
So yeah, actually such scenarios, this was what inspired us to start perinatal palliative care, because there was a family who said that our baby was born, the baby breathed for some time, but the baby was just put into the dustbin. We saw the baby breathing and then we didn't know what to do after that. That was one scenario. And another scenario where the parents said that, what if I would have known that my baby has this earlier, would have been more prepared and I would have faced it better and given a better care. So these two instances, when I personally faced in my palliative care when I was working, this inspired me to start perinatal palliative care. As ma'am says, if the gross hydrocephalus is very gross and we know that it's not going to really help in life for the baby to live, then we tell them that we ask them to what extent they would like to resuscitate, or even intervention. We tell them that this is a point where don't think what we can't do, think what we can do to keep the baby comfortable. So usually in such a case, we avoid even even admission to the NICU, because we give bedside comfort care and we allow the mother to feed the baby. If no further like umbilical vein or we are not doing anything harmful to the baby, we are giving comfort care as per the parents' wishes. If they say right now we want a cannula, but after we go home we don't want any surgery, then yes, we keep a cannula. We tell the neonatologist they want to this extent. If the baby arrests, don't ventilate. Then we are there to give end of life care. In case the baby, what we tell them is, we don't want the baby to suffer and we don't want you to suffer seeing the baby suffer. So in case you are not going to ventilate, that means your baby is going to die, but the baby might gasp, the baby might have distress. That we won't allow to happen. So we are there to support that. But if they want to initially be in the hospital, then go home, but later not go for surgery, then if the baby develops dystonia or seizures or spasticity, then we take care of those things.
I do have a question for Dr. Archana. So how is the legal aspect? So how protected I am in whatever you have described?
It's all when we document, especially for compassionate extubation, it's always a mutual shared decision which is documented with both the parent's signature and the neonatologist also. And in such conditions also, we document everything and ask them till what extent they want to. We have a hospital policy in Nilofer Hospital wherein they can say till what extent they want to resuscitate. So if they, even a home care baby with severe neuroregression, if the baby aspirates at home, then we immediately inform the ESR when they come for admission. In case, usually such babies go to the hospice, they don't even come back to the hospital. But in case they come to the hospital, then we inform the PG that this is a child under palliative care and they've already informed before that they don't want a resuscitation or a ventilation. So that coordination is a little difficult. Sometimes they do get ventilated and die on a ventilator, where my madam says palliative care has failed. It has happened many times, but it's difficult because parents won't, it's very difficult to let go. But it all depends on the number and the quality of counseling that we do. I think that is a basic thing.
So one of her question to me was, can you kill the baby?
No. So many times they think that palliative care, morphine is something like euthanasia. So that also we say, we are giving a medication which will not hasten death, which will not prolong death. It will just make the baby comfortable. So whatever is to happen, it will happen because of the disease when it has to happen. It will not be hastened by our medication. So we are not going to do anything which will hasten or prolong the death. It is only to control the suffering of the baby. So that is what is told.
So, see, these questions that I'm asking, it's look very cruel the way I'm putting it. But
they do
when
ask
I
that, I
was
agree.
talking to the mother, her concern was that her baby should not suffer.
Yes.
So see, it's not like that she doesn't want baby. She wants
Yes.
everything. She doesn't want the baby to suffer. So
Yes.
like the way she was talking, means I found it very difficult to answer because I don't have a proper setup like what you explained, that after home what you can do.
But
So,
we should never, I think, I mentioned about illiteracy and no education, but we should never underestimate. We had mothers who had not been to school and who had like this hypoplastic left ventricle. So when she came to know in TIFA, she said, I just want to experience delivery. I want to have the baby for 5 days also, no problem. Everybody has told me go for termination. No, I don't want to. I want to say I have delivered a baby. I want to experience that and let the baby be there for 5 days. And she was so much pro palliative despite any kind of education. So it all, like our children with cancer, I mean, I'm going off the topic, but children whom we treat with cancer, adolescents, they have so much spiritual, the way they talk spiritually about their death approaching, it is very, very amazing. So every child we learn so much, and every child teaches how we have to take care of the next child, I think.
So one of the last part of discussions, he said, okay, fine, it is very difficult. So if I take the baby home uh, and I don't feed, the baby will keep on crying.
Manish,
So that is like a,
you're talking about very specific questions, but
no,
can
this is happened
yeah,
to
yeah,
me
I
a
agree.
week back. That's
I
when
agree. I agree.
Again, during feeding
No.
part,
yeah.
we say either it should be only oral feed if possible. Again, there we say oral at risk feeding in such a case, or a tube. So in that situation, when end of life care is given, a tube again is a source of pain and distress. So again, we leave it to the mother whether they want a tube and then give tube feed, or then just keep the breast with at risk. The baby might aspirate, but at least she is happy that she has given the feed. So again, this boils down to that kind
No,
of
so
concept.
what I wanted to summarize here with the point what I got from you. So if any type of this scenario, if baby is sick and die, that's easy. For the mother, that is very easy. That death has happened in the labor room.
Right.
If baby survive, okay, fine. Cost is involved if the baby is lying in the nursery, so they are worried about that. They are worried that how long that will continue, and then suppose if they are taking the baby home, what they can do to comfort the baby. That's all they wanted to see, and that's what the questions I was.
Yeah, I agree. I completely agree. They will have specific questions like this. But when they ask about something, for example, about, like you said, how long will my baby live? Will the baby die
Right.
immediately? How long can you tell me
Right.
how long? One thing we did not talk about is about admitting to our uncertainty about these things. Like why it makes conversation much more easier when we tell them that I don't know how long the baby will
Yeah,
live.
we
Right.
do say that.
It comes across as being more honest, and it is more honest. We
Yes.
don't know really how long the
Yes.
baby
Yes.
will live.
Yes.
The second thing is that when we were answering these specific questions, like what Uma was suggesting, what she'll do, we assume that when we talk to them, they understand this fully. There is a surprising lack of research into what actually parents understand and take away from this communication. What you say is not always what they hear
Right.
and understand. And what is their experience of this communication? If you look at palliative care research in India, I mean, we are talking about the clinical part here, but about research, there is hardly anything related to palliative care research, and especially about this communication part that we are talking about. In fact, right now we are starting a project related to it. And when we were doing the review of literature, we realized there is hardly anything related to it. Our attempt was only to try and improve our own SOP based on our understanding so that we can have a structured communication policy. Like when Madam talked about this wish, worry,
Yes, that is.
wonder
Yes.
technique, that is there is a structure to it. So there is a structured way of doing this. There is it is no, it
Exactly.
has to be tailored to each baby and parent and family, but there is a structure to this conversation that we haven't really imbibed. We all have SOPs, but about this communication part, we often don't admit to uncertainties. We speak as though we know the
Yes.
answers to many things. I think we need to take a step back. There should be a research component to it to try and understand what parents experience in our context, because in the Western context, it's very different. They often come and tell you that they want to spend time with the babies, take photographs, create memories. Here, often parents come and tell us, mothers tell us that I don't want to see the baby. It's too painful. I don't want to take photographs. Very different kind of families.
Actually, like when we are antenatally counseling, give me what happened to you. Previous neonatal death, they would have referred to us for an antenatal counseling. Please tell what happened to the baby. Just give the discharge summary. We burnt all the discharge summaries or all the things. Please give me a photo. Many times we have heard parents telling we wanted to erase the memory, so we have not kept any record. So we are really clueless where to begin, how to counsel this mother, what should I tell as risk of recurrence for the ongoing pregnancy as such. So actually we cannot really equate the mindset of a Indian, and also the family, the extended family, very extended family plays an important role in all the decision making. We cannot assume that only the couple is going to take decision, or couple plus the grandparents are going to take decision. So these are some of the practical difficulty which we have faced, and I completely agree with Nishad that memory making, they per se, of course we are not going to compel them for memory making. Even if we are telling that, okay, like in my training abroad or in UK, like we tell that death in the hands of the mom or dad, like the nurses know what is a bereavement. They kind of make the baby die. Even when there is, we know that this baby may not make, no mother would like to hold the baby, touch the baby. Sometimes father prevents the mother from even entering into NICU, telling that, um,
No, I think these are cultural, because I have
Before
few
doing the
mothers.
palliative care, I was in the same scenario of thought. But after having, as sir said, that structural conversation and communication, we also have a surprise question in palliative care. What will I be surprised if I see this baby alive after 6 months? So definitely we should never say, we should say we don't know how long your baby will be alive, but we should have the surprise question for ourselves to have a care plan for that child. Will I be surprised if I see this child after 1 year? Yes or no? So it's not, when they ask, when will my baby die? We should say, as sir said, we nobody knows. But as long as your baby is alive, then we'll try to keep him comfortable.
Can I make one comment?
Yes, please.
Dr. Archana, so as I understand it, for this particular scenario, you preferably would not have admitted the baby into the NICU at all if you already had a communication with the parent and if that was the parent's wishes.
Usually the baby will be admitted, sir. From there, whether the baby will go to a neurosurgical opinion, sometimes we say take that opinion also, because the parents want.
Yeah.
After that, whether they'll go for a VP shunt or then they go home, because we say we'll take care of this baby home. If you don't want a VP shunt, we'll manage the symptoms at home.
Yeah.
So
the
that-
second thing is, you would not have started oxygen.
If
You
they
would
don't
not-
want, if they don't want.
And you would not have put an umbilical.
Yes, after explaining, if they don't want any kind of painful intervention, then we won't put. No, if they don't want, not painful, I mean, if they don't want any procedure, it's all left to the parents. We
Okay.
explain both the pros and
because like
cons.
why we chose umbilical line over peripheral line is because umbilical line is painless,
Yes.
and like we don't even need a vent flaunt, because here in a private sector the cost also is important.
Correct, correct.
Okay, they will think that like
Yes,
I am
just giving
shifting
up
the
on
baby
everything.
NICU only because like they will say that NICU charges will be there. Like in fact sometimes both the obstetricians and the parents will be telling you just leave the baby in the labor
That
room
we should
itself.
not do.
So what I was just summarizing what I think I learned from this conversation. So if you have a scenario like that, so what is important is the communication before delivery in multiple setting, and preferably with a group of people, not just mother or not with father. It's like,
We have
so
religious leaders also who came and we once had to do a compassion extubation.
Yeah.
The Shamla. she
yeah,
wanted
I'm
to
just
ask.
summarizing, then you can ask. So this is so communication, the first thing that we should do it on multiple setting, come to a common decision. So like, okay, if baby dies, this is what happened. If baby survive, this is what we will do. And everything should be documented very well. Should be in the system where registrars or anybody can approach if delivery happens suddenly sometime in the night. So this should be clear and should be communicated to your team that this is a plan, what is made for this baby. And if these things are clear, I think it will be easier for the mother and easier for the doctor.
See, I have two different situations. It's unique to the, different from what you're saying. Here, this is a planned condition or situation where this child has this kind of anomaly and the family actually has had time to mentally, emotionally prepare for it. Now, this is a litigational era. There are times when something is missed in the antenatal scan, and for something as trivial as we had a female baby, completely viable, 34 weeks with an absent thumb. Okay, so they said, in our family, we are all perfect. How did this happen? As if I chewed off the thumb, the way they were saying. So they said, we don't want care for this baby. So that's one situation.
Sorry. I
Yeah.
think we are deviating from our topic.
No, no, these are situations that arise, and I know that I'm
Yeah.
deviating, but I just want to know. There's another situation where the family cannot afford preterm care, and there was a sudden preterm birth around 25 weeks or something, and they don't want us to do anything. They don't want us to transport anywhere.
Yeah, so
So
that is the
what's
second
our
thing. The second
position?
question was the second scenario that I wanted to ask was that pre-viable preterm. Like depending on the unit, it may vary. Some units say 25 weeks, some units say 24 weeks, some units say less than 26 weeks we don't touch. But in that scenario, what we do, like suppose we don't touch less than 25 weeks, but we tell them that, okay, there are a center in the Chennai who can manage. But suppose they say, no, fine, we don't want. So how do you proceed
For
with that?
me, I work in a government hospital, so we give services there. So everything is free of cost. So this part really doesn't come up. As ma'am said about the NICU charges, it's all free. Our services are free and their treatment is also
Not
free.
for the money, not for the money.
Uh-huh.
I'm just saying, so like say 24 weeker,
Yeah,
23
so then
weeker.
this baby, if it is such a scenario who don't want, I mean, you are saying they don't want to continue further.
No, because
stay in the
23
hospital.
weeker, if you treat, you know that this is the outcome going to be when you discuss with the parents and parents say, okay, fine, we don't want anything, we just want.
So that baby, we in our scenario, we'll shift the baby to hospice because we have a pediatric palliative care physician there and round the clock palliative care nurse team is there. So the baby will be in the hospice as long as the baby lives. Otherwise, if the baby goes home, then we make it a high priority visit and then give end of life care at home every alternate day. So it depends on each baby because we have this continuity in care. I think it's easier for me to tell, but it's not so easy in a scenario like that.
See, this is very easy to answer. It's easy answer is coming from you because
We
you have a hospice, you have
Correct.
system in place. It's like if I hand over baby 25 weeker, sometimes they just go out and they see, okay, baby is breathing, and next day it will be in newspaper, like baby handed over. So what I mean to say is that right now we don't have any way of like hospice or end of care at home. These things are not in the place right now.
Good documentation anyway, even for us also, that is the main thing about what the parents have given consent for, so that we'll avoid, going into any litigation later.
Can I just, can I just share the
Yes, please.
experience? Yeah. So I'm Dr. Kiran from Mumbai. So very nice talk. Actually, I missed half of this thing because I was doing some posters. But so I'll share my experience. I've been doing palliative care for 15 years and last 3 years in India. And we established palliative care program in Wadia Hospital, very well established and very much on the lines which ma'am and was been discussed. So one thing which will help you to answer your this thing was like the home care program, although started in Wadia, the system is built there. Now I moved to private hospital. All palliative care services we have established because the thought process is there, including doing palliative extubation, which is a big private setup, which we are doing. But the home care, we are getting help from the Wadia. So Wadia now, because we were collaborating, so they have the staff to go for home visits. So they are picking up these babies, which we are discharging home. And three of my follow-ups are in palliative, like at home. We did DNR, and the DNR is placed at home also. So they are accepted that the baby deteriorates, then they will go to hospital and do not resuscitate. But they get visit from the palliative care from the Wadia hospital. And obviously it's small amount which is paid, their systems is working. So I think every area, if they have a nodal center where they can establish a home care, palliative care, then I think even
No,
private hospital.
Kiran, how does that answer the issue of how to make a call?
Yeah.
That addresses the support system.
Yes.
When a 24-weeker is born in a setting, that
So-
will still involve some decision making first about
Yeah.
what to do.
Yes.
And second, it will still involve some cost if the baby survives, let's say, for some period.
Correct. So, I mean, one is that like you transfer to this place where these systems are there. Because see, I think the problem comes when we are continue to care. Suppose a 23-weeker, 24-weeker is born at my care, in my hospital where parents have decided and we mutually agreed as a shared responsibility, this baby is not going to survive. Then actually, till the baby survives, we have to support and parents agree. And then obviously we paid a DNR, DNE and de-escalation of the care, which includes extubating to an NIV and not to resuscitate. So obviously that there will be few days which will pass by and the decision will change. Suppose we take that, okay, we extubate and baby might die today. It will not happen. Then next baby prolongs for 3-4 days on NIV. then my next steps is there. What are the next steps you're going to do? Whether you're going to downgrade it to CPAP or just nasal prong oxygen, which again mutually agreed. So this is where the gray zone arises, but then eventually you make a plan. And the last plan will be then discharging this baby who is home. But obviously the peri-viable gestation is a very gray zone where how you take the decision. And with my experience, I think most of these babies, when you withdraw support, then they don't last very long. It's a matter of 3-4 days. And that much cost, I think the parents do bear. Or you transfer them to a government center, which is happy to accept it in that state. So I don't know if that answers the question. Because it's very complex.
Yeah, thank you, Kiran. Only one last comment. Time is the factor. Actually, many times for shared decision making, we may not have time. Because like she would have ruptured membrane, she will be delivering and the delivery is imminent and we do not have time to do an in utero transfer for sure. So, and again, sometimes, all the EDDs calculated based on the LMP might be wrong. You might get a bigger baby. So there are varied ranges of antenatal care, which is, unless and until I'm going to see the baby in the resuscitation suit and my team there takes a decision, okay, let us tube the baby now and then take a shared decision making little later because I do not have time to decide or to make a shared decision making at this point. Even for the particular gestation age, even though we say 24 weeks, 24 plus 1 or 24 plus 6 does matter. Or 25 weeks, say for example, 25 plus 1 or 25 plus 6 is almost 1 day less than 26 weeks. So I think there are a lot of other factors, whether appropriately grown, etc., etc. So a lot of factors. Parents might change their mind. They might initially, because of the shock, they might think that, okay, I do not want resuscitation. Then they might think that, okay, after seeing the baby, they might get some emotional attachment and they might change their mind to care, continue the care, which might change at any point of time during the NICU stay.
Can I make one comment? Don't mind?
Yes, please.
Yeah. So I think we are now going into the micromanagement. Actually, the first step is step back and say, do you have a hospital policy in place? Not just an SOP, a full one. Like you say, how do you counsel? What is the communication mode? The full step in place. I would say that you start with that and then work your way through the fine details as you go on. Because then naturally, there is you have in Chennai, we have home care. It's there. In fact, my wife is, that's how we got her in. She does pediatric palliative care. Their home visits are already in place. You have palliative care in CMC Vellore.
Right.
They are taken over a new building now. But they don't have a pediatric and a neonatal one. Now, how to integrate that into your setup? So this is something they started palliative care in 2008, if I'm right. That's when you started home care visit by, but they started perinatal palliative care only in 2024. So you can see that long it took. So initially, all our assumption is that it's all cancer, cancer, cancer. Hardly 40% of the patients I understand in pediatrics is actually cancer.
Very true.
And the large number is actually perinatal. So the first thing for all institutes is, do we have a policy? Do you have a person who's going to be the ambassador or says, I am going to take this up? Now that person now becomes the integral coordinator for the home care, for the hospice, and for the mother and the obstetricians. That is what I think that is what Archana did there. That is what you took perinatal care as your passion. And of course, your passion speaks out very clearly here. Thank you.
So this is fantastic. I think we should bind up. You want to add anything, ma'am?
No, we do face such situations, what ma'am said so many times, change of decision. First time agreeing for ventilation, suppose extubation, coming second time, then they will only say no. So there are so many different situations what we face, but we try to do our best in whatever situation possible.
So if you remember Dr. Archana's talk complete, the thing doesn't stop with the death of the baby. So the next step is mental well-being of the parents. One of the factors that what we have recognized that parents always have the guilt that they have done something wrong, that's why baby has died. So I think as a neonatologist, what we should try when we talk to them, we have to reiterate that it's not your fault. It's not your fault. It just happened. It can happen to anybody. And the follow-up calls after 2 weeks or so, those are really needed. So
there was a mother who felt that she got a baby with hydrocephalus because she had too much of Sprite. So the moment we told her in first trimester that's not because of that, she said that was the first night I slept so well after so many months, because like what
Yeah.
you said, guilt.
Yeah. So we should make it as comfortable as for the parents. Thank you all for the nice discussion.
Thank you so much.
Thank you.
Thank you, Dr. Manish sir, Dr. Archana ma'am, Dr. Nishad sir, and Dr. Uma ma'am. I request Uma ma'am to give a moment to